Hi, I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G.
Today we'll continue our discussion on breech presentation. So, as we said last week, if we detect a breech presentation at term, a woman has three options: elective caesarean, ECV and cephalic vaginal delivery, and vaginal breech. Last week we spoke about diagnosis of breech and how to perform an ECV. So now it's time to get into vaginal breech birth.
When a woman presents to birth suite in labour, and with a breech presentation, there's often a real mixed bag of emotions. The idea of a vaginal breech birth tends to incite a mix of anxiety, curiosity, and excitement. Everybody wants to be involved because a vaginal breech delivery just doesn't happen that often. Now, C-sections have only been performed regularly since 1950, and ECV wasn't popularised until the mid-16th century. So surely there was a time when all breech babies were born vaginally, right? Why is it that we're so uncomfortable with the idea of a breech vaginal birth now? I thought we should have heaps of experience by now.
Well, it wouldn't be a proper Uterine Sound episode if we didn't delve into some history. Vaginal breech birth did used to be the only option for delivery of breech babies, but that doesn't mean it wasn't without complications. Babies born by the breech were exposed to complications like head entrapment, cervical spine injury, HIE, and death. Because of this, people developed ideas to help make the delivery of these babies safer. ECV was developed to allow babies to be born for cephalic instead of breech, and instruments like the Piper's forceps were invented to help deliver the aftercoming head. As the safety of caesarean sections improved, more breech babies were also delivered via caesarean section instead of vaginal birth. By 1980, about 15% of breech babies were born by caesarean. Now, at the time, several cohort and observational studies started to come out reporting better outcomes for breech babies delivered by a Caesar, which started to shift the attitude towards caesarean section as the best mode of delivery for breech. By the 1990s, the percentage of breech babies delivered by Caesar had risen to 75%. Still, the mode of delivery remained controversial, with some clinicians questioning the quality of the evidence and calling for a randomized control trial. It wasn't until the early 2000s that the safety of vaginal breech birth was seriously called into question, and this was all due to the Term Breech Trial.
The Term Breech Trial. Now there's a landmark trial. We decided we couldn't just talk about the Term Breech Trial in an Evidence with Anne episode because it's so pertinent to the discussion of vaginal breech birth. We'll discuss it briefly now, but it definitely deserves a whole episode to itself. The Term Breech Trial was published in The Lancet in 2000 by Hannah et al. The full title of the paper is Planned Caesarean versus Planned Vaginal Birth for Breech Presentation at Term, a randomized multi-center trial. It randomized women with a singleton pregnancy in frank or complete breech presentation to planned caesarean or planned vaginal birth. This was the largest randomized trial ever published on term breech mode of delivery and was really one of the key trials that changed how breech presentation was managed. The study found that babies in the planned caesarean group had a significantly reduced perinatal mortality, neonatal mortality, and serious neonatal morbidity. Put in a different way, babies born by vaginal breech were more likely to die of significant morbidity. The difference was actually quite significant, with a complication rate of 1.6% in the planned caesarean group versus 5% in the planned vaginal breech group. Now, as you can imagine, this resulted in a huge change to clinical practice.
Based on the outcomes presented in the Term Breech Trial, ARCOG and ACOG changed their clinical guidelines to recommend that all women with persistent singleton breech presentation at term should undergo a planned caesarean delivery. Because of this, women with babies in the breech presentation were encouraged to deliver their babies via caesarean, and the rates of vaginal breech birth significantly declined, along with the skills of midwives and doctors in delivering vaginal breech babies. According to the Australian Institute of Health and Welfare, in 2021, 90% of persistent breech presentations were born via Caesar.
Far out. No wonder everyone's nervous about vaginal breech births. Like, if you think about the stats, 3% of babies are breech at term. That's about 30 in 1,000. Then the success rate of ECV is 60%, so that leaves about 10 in 1,000 of all babies remaining breech at term. Of those, 90% will have a Caesar. So realistically, it's only 1 in 1,000 babies that's born by vaginal breech birth. Our birth units do what? Like 4,000 births a year? So that's only like 4 vaginal breech births per year to maintain skills in a vaginal breech birth. Like, you don't even always have the same staff on.
To further drive the nail into the coffin of vaginal breech birth, a large study conducted in the Netherlands following the Term Breech Trial found that the rapid increase in caesarean sections resulted in substantial improvements in perinatal outcomes, leading to halving of perinatal mortality rates and even greater reductions in the incidence of perinatal birth trauma. This further supported the clinical recommendation to deliver breech babies by caesarean. Since then, there has been a lot of debate and reanalysis of the Term Breech Trial and the topic of the ideal mode of delivery for breech babies. It has certainly become quite controversial. Do all breech babies really need to be born by caesarean? There have been quite a few studies since the Term Breech Trial which have not supported its findings. While delivering breech babies by caesarean does seem to be slightly safer than a vaginal breech birth, there are risks of caesarean section, and the risks of vaginal breech birth don't seem to be quite as bad as the Term Breech Trial suggests. In fact, some studies suggest that in appropriately selected cases with an experienced operator and strict protocols, vaginal breech birth is not that much more risky than a cephalic vaginal birth. Because of these questions and analyses, there has again been a change in clinical practice guidelines, and more facilities are supporting vaginal breech birth in selected cases.
The current general consensus by RANZCOG, ACOG, and the Green Top Guidelines is that vaginal breech delivery can be a reasonable option, but only in selected patients. We'll flesh out the evidence around vaginal breech birth a little more in our Evidence with Anne episode, but for now, let's get into what's required to support a safe vaginal breech birth.
So, the RANZCOG guideline recommends that the essential components of a planned breech birth include appropriate case selection, availability of skilled birth attendants, management according to a strict protocol, and appropriate infrastructure. So let's start with case selection. Who is our ideal candidate?
Ideally, the baby should be in a frank or complete breech presentation. It should weigh less than 3.8 kilos but more than 2.5 kilos. The fetal head should be flexed, and there should be no other contraindications to vaginal birth.
Contraindications to vaginal breech would include cord presentation, fetal growth restriction or estimated fetal weight less than the 10th centile, fetal macrosomia or estimated fetal weight greater than 3.8 kilos, any presentation other than frank or complete breech, hyperextension of the fetal neck, fetal compromise such as abnormal CTG, fetal anomaly incompatible with vaginal delivery, for example hydrocephalus, and any contraindication to vaginal birth in general, like placenta previa.
How do you tell if the fetal neck is hyperextended?
On ultrasound, basically you view the head and cervical spine in a sagittal plane, and you're looking to make sure that the angle between the mandible and the cervical spine is less than 90 degrees. This would denote a flexed head. If the angle is greater than 90 degrees, then this would be suggestive of fetal neck extension. Yes, all three of us are currently flexing and extending our necks. Hyperextension is when the angle between the mandible and the axis of the C-spine is greater than 150 degrees. Now, this is important because babies with fetal neck hyperextension are much more likely to get head entrapment. They're also prone to C-spine injuries at delivery. Interestingly, a hyperextended fetal neck can also be a result of abnormal development of the C-spine, and so C-spine injuries at vaginal birth are not always attributable to the mode of delivery. They might have occurred antenatally.
Oh, okay, that makes sense. Then what about the availability of a skilled birth attendant? We've just mentioned that the rate of vaginal breech birth nowadays is so low that it's almost impossible to maintain your skills in vaginal breech. How do we go about getting a skilled birth attendant?
So there are still many clinicians around who trained at a time before the Term Breech Trial was published, so these people are likely to identify themselves as skilled in vaginal breech delivery. Some consultants also trained overseas where birth rates are quite high, and so their exposure to vaginal breech births may also be higher. People who regularly manage delivery of the second breech baby with twins can also be considered experienced. For the rest of us, we simply cannot rely on exposure to vaginal breech birth alone. There are a few courses, BABE for example, otherwise known as Become a Breech Expert, which expressly focuses on training clinicians and midwives in vaginal breech delivery. Simulation can also be used, and you can also practice your breech manoeuvres when you deliver a breech baby at caesar. Having a skilled birth attendant is incredibly important. And by a skilled attendant, we don't just mean someone who can manage a normal breech birth. You really want someone experienced with the complications of a breech delivery. For example, when manoeuvres are required, or especially in the case of an entrapped head. These situations are difficult to manage even with a skilled birth attendant. And if you have someone who is untrained managing these scenarios, that's when the risk of adverse perinatal outcomes is significantly higher. Providing a skilled birth attendant also means that you have someone able to cover the entire duration of the labour. This should account for fatigue and shift changes. If the hospital cannot support a skilled birth attendant, then we need to counsel patients that vaginal breech birth is likely to be associated with greater risk and offer antenatal referral to a unit where skill levels and experience are greater.
So let's talk about the infrastructure needed to ensure a safe vaginal breech birth. Hospitals that support vaginal breech must have the ability to offer and perform CTG, have immediate access to caesarean section, and they must be able to support the availability of skilled birth attendants. Appropriate neonatal care should also be available. It's definitely not a good idea to offer vaginal breech birth in a remote community with minimal obstetric staff and no theatre access.
Okay. So before we get into the nitty-gritty of how to manage labour with a breech presentation, let's summarise the answers to some potential exam questions.
Okay, what are the ideal criteria when selecting a patient for vaginal breech birth?
The ideal patient selection includes frank or complete breech presentation, estimated fetal weight less than 3.8 kilos but more than 2.5 kilos, the fetal head that's flexed, and no contraindications to vaginal birth.
What are the contraindications to vaginal breech birth?
Contraindications to vaginal breech birth include any presentation other than frank or complete breech, fetal growth restriction or estimated fetal weight less than the 10th centile, fetal macrosomia or estimated fetal weight over 3.8 kilos, cord presentation, hyperextension of fetal neck, fetal compromise, fetal anomaly incompatible with vaginal delivery, and any contraindication to vaginal birth.
Okay, and what are the RANSCOG requirements for a safe vaginal breech birth?
So the RANSCOG requirements for a safe vaginal breech birth include appropriate case selection, availability of skilled birth attendants, and management of labour according to a strict protocol.
We should have made you answer these questions, Anne. This is good revision.
Yeah.
Yeah, that's what I was thinking. I was like, why are you getting Carla to answer these ones?
And your turn.
What?
Spit it back.
What are the institutional requirements to facilitate a safe vaginal breech birth?
So, continuous electronic fetal monitoring, a paediatrician and anaesthetist that's available, immediate availability of a caesarean, and experienced obstetrician being available, with provisions to manage shift changes and fatigue.
So let's do a little bit of a case.
All right. So let's say we're seeing River. She's a nultiparous woman who's currently 36 weeks with a breech baby and is interested in pursuing a breech vaginal birth. If you remember our last episode, the first thing to do is arrange a formal ultrasound to check for reasons for breech and contraindications for vaginal breech birth. We want to exclude fetal neck hyperextension, fetal macrosomia, and any contraindications to vaginal birth.
Next, we want to discuss the risks and benefits of all of her options: ECV, caesarean section, and vaginal breech birth. We already went through the risks and benefits of ECV and Caesar in our previous episodes, so if you want to recap on that, go back and have a listen, or check out our Instagram summary slides. The specific risks of vaginal breech birth include a slightly increased risk of perinatal mortality compared with caesarean, so that's 2 in 1,000 for vaginal breech, versus 1 in 1,000 for planned cephalic birth versus 0.5 per 1,000 for a caesarean section. There's an increased risk of low APGAR scores and serious short-term complications, but no increased risk of long-term morbidity. There is a 40% risk of emergency caesarean section, which carries higher risks than an elective Caesar. Cord prolapse or cord compression can compromise fetal oxygenation, and there's a risk of fetal head entrapment resulting in HIE or death, although this is really quite rare with term vaginal breech births and more common with preterm vaginal breech births where the diameter of the fetal hips is smaller than the diameter of the fetal head. There is also a small risk of fetal injury, such as bony fracture, soft tissue injury, or C-spine injury. The risks of vaginal breech birth should also be discussed with reference to the experience of the clinical team and the infrastructure available.
A balanced discussion should also include the general risks and benefits of vaginal delivery, as well as the risks and benefits of alternatives such as ECV and caesarean section, including the impact on future pregnancies.
Okay, so if counselled River appropriately, she is aware of all of the risks and benefits of all options, and either she is delivering at a facility that is able to meet the requirements for a safe vaginal birth, or she's being referred to a facility that can offer this, or she's decided to birth at a facility that does not meet the requirements to provide a safe vaginal birth against recommendations, but we've encouraged her to still birth at hospital rather than at home. What do we do next when she's in labour?
Well, firstly, let's talk about the onset of labour. Ranscog states that induction of labour is not typically recommended, so ideally we want to await spontaneous onset of labour after 37 weeks. Similarly, augmentation should be avoided because adequate progress may be the best evidence for an adequate fetal-pelvic proportion. If progress is slow, that is generally an indication for a caesarean section. ARCOG suggests that augmentation may be considered for slow progress only if the contraction frequency is low in the presence of epidural analgesia.
The first stage of labour should be managed according to the same principles as a cephalic presentation, but with continuous CTG monitoring. Remember, if you need to, you can put on an FSC on the fetal buttock. The reason we recommend CTG is because there is a higher risk of cord compression and subsequent fetal distress. If there is evidence of significant fetal distress, then a Caesar is recommended. Fetal blood sampling should generally be avoided on the buttocks. The membrane should also be left intact because rupture increases the risk for cord prolapse. If rupture of membranes does occur, an immediate VE is required to exclude or detect cord prolapse.
An epidural may be considered if the patient desires. Epidurals are useful because they reduce pain, but also because they reduce the maternal urge to push involuntarily before full dilatation. They're also really good anesthesia if obstetric manoeuvres like forceps are needed to facilitate birth. The effect of the epidural on the success of vaginal breech birth is unclear, but it's likely to increase the risk of intervention.
Once we get to the second stage, a vaginal exam should be performed to confirm full dilatation. A passive second stage is recommended to allow the breech to descend to the perineum before active pushing. If the breech is not visible within 2 hours of the passive second stage, then a caesarean section should be recommended. Active pushing should not be encouraged until the breech is visible and has descended to the pelvic floor. Once active pushing commences, if delivery is not imminent after 60 minutes, a caesarean is also recommended.
Now, there is limited data on maternal position at delivery and outcome of breech birth. The all-fours position is okay, although if manoeuvres are required, this can be very difficult. While some women may request to birth on all fours, standing or on a birth stool, the attending clinician and the person with the most experience with breech delivery may feel more comfortable supporting in the dorsal or lithotomy position, and therefore may recommend this position for birth.
Okay, now we get to the interesting part, the actual delivery of the breech baby. During second stage, there are 3 ways to deliver a breech. Spontaneous delivery, this is where there is no traction or manipulation of the fetus. Assisted breech delivery, and total breech extraction. This is where the feet are grasped and the entire fetus is extracted. Ideally, it should only be used for the second twin, and not singleton, as the cervix may not be dilated to allow the passage of the head. Basically, the clinician grasps one or both, ideally both feet. They apply gentle traction on the feet and ankles downwards until the hips are delivered. At this point, the rest of the typical breech manoeuvres can be used.
Now, ideally, we are aiming for spontaneous delivery. We've all heard the saying, hands off the breech, and this is super important here. Tactile stimulation of the baby might result in the Moro reflex, leading to extension of the arms or neck, which can then make delivery of the fetal head and shoulders difficult. So once the mother starts actively pushing, you just sit back and wait. These breeches are the dream because virtually no assistance is required from the clinician. They tend to just come out beautifully. Manoeuvres are only required to correct any deviation away from a normal delivery. If the back starts to rotate posteriorly, you can gently rotate the baby without traction to ensure that the back remains anterior. The legs will usually deliver spontaneously by the time the baby has delivered to the umbilicus. If assistance is required here, you can use Pinard's manoeuvre. This is difficult to explain in a podcast, but basically you exert pressure in the popliteal space of the knee, flex the knee, and then guide the thigh away from the trunk as the trunk's rotated in the opposite direction. It's very similar to what you do at caesarean section.
Again, be patient and wait. The next landmark is the scapula. Usually, the baby will descend spontaneously to the level of the scapula, but if there is a delay or if you need to expedite birth for any reason, then you can help out. To do this, you would place your thumbs over the sacrum and fingers resting on the anterior superior iliac crests. You apply gentle, steady downward or outward traction until the scapulae are visible. Again, only do this if you absolutely have to expedite delivery. Otherwise, hands off the breech.
The way I always remember it is thumbs on bums.
Oh, that's good.
That is
thumbs
good.
on bums.
But like not the cushiony part of the bum, on the like bony part of the bum. But also not on the abdomen, to remind you to touch the
thumbs
pelvis.
on the bum.
That's the goal.
Once the scapula is visible, the arms should also deliver spontaneously, one at a time, in the anterior-posterior plane. But if they don't, you will need to help them out. Gently insert a finger in the elbow to hook the arm and flex it across the chest. If the arms are nuchal, then you might need to use Loveset's manoeuvre. With Loveset's manoeuvre, you again hold the baby by the pelvis. Only ever hold the baby by bony prominences. This avoids injury to the internal organs. You then rotate the baby through 180 degrees to deliver the first shoulder and arm, and then in the opposite direction. You might need to slide 2 fingers along the humerus until the elbow is reached. Then they sweep the forearm across the chest and out the vagina.
If the arms are really stuck, then you might even need to rotate the baby so the chest is facing the symphysis pubis. This helps to dislodge the nuchal arms and allows them to be swept down and extracted. This can sometimes be quite tricky, and there's a risk of shoulder dislocation or fracture. However, these will heal and are much more preferable to doing nothing, which can lead to prolonged dystocia and birth asphyxia.
Okay, so now we get to the head. Once the arms are delivered, the fetal body should be allowed to hang again for a few seconds until the nape of the neck or the hairline is visible. At this stage, the head is likely to deliver on its own, but again, if it doesn't, you need to intervene. If the hairline isn't visible, you may need to rotate the baby to the back up position again and have an assistant apply suprapubic pressure to encourage head flexion and descent. This is known as the Bracht manoeuvre. Once the fetal occiput has descended underneath the symphysis, the head may be delivered. At this point, delivery of the aftercoming head may occur spontaneously, with Piper's forceps, or with the help of the MSV manoeuvre.
Wait, what's the MSV manoeuvre?
Oh, you've given me to try and say this name. The Mariso Smelly Veit? Or the MSV
please.
manoeuvre?
Does anyone know? Morris says smelly feet. Morris has smelly feet.
Mauricio Smelly Feet. I don't know. Yeah, that's what I
I'm
say.
not sure. Or the MSV manoeuvre, as it's more readily known, may be needed to deliver the fetal head. The baby rests along the clinician's right forearm with the legs straddling either side. The middle finger of the right hand is placed on the maxilla or in the baby's mouth, and the second and fourth fingers are placed on the malar eminences, the cheekbones. You flex the head with your right hand. You also apply downward traction while applying counter pressure to the occiput with the middle finger of the left hand, so essentially using your opposite hand to help flex the head from the back. There is also the Burns-Marshall technique. This is when the clinician's assistant grasps the ankles of the fetus and raises the body vertically above the mother's abdomen before the head is delivered. The clinician can use forceps or the MSV maneuver to help. This is best avoided as it can result in hyperextension of the fetal neck and C-spine injury. Ideally, you want to avoid raising the trunk no more than 45 degrees above the horizontal.
Forceps can also be used to help deliver the head. You would normally get your assistant to hold the feet and swing the legs up to no more than 45 degrees above the horizontal. A towel can be helpful here as babies can be very slippery. The operator then applies Piper forceps. These are much better than Neville Barnes forceps because they have a backward curve at the shank, which means you don't have to elevate the fetal body as high to keep it out of the way of the handles. I've also seen Neville Barnes forceps be used, but this can be annoying. If you think about how you usually apply Neville Barnes forceps with the blades upwards, you quickly realise that this is hard to do when you've got the body of a baby in the way. The actual technique of forceps for the aftercoming head is slightly different to forceps for a cephalic birth. We suggest learning this technique of someone experienced.
So this has taken us a long time to explain, but in reality, the second stage should be quite quick. Remember, the active second stage should take less than 60 minutes. Otherwise, we typically recommend a caesarean section. If the baby isn't descending spontaneously with active pushing, then that may also be an indication for caesarean, as this can be safer than an assisted breech extraction. The birth of the buttocks to the head should take less than 5 minutes, and if it isn't, then intervention is required.
Again, ideally we're aiming for spontaneous delivery with hands off the breech, but we may need to do manoeuvres to prevent deviation from normal. Reasons why we consider using manoeuvres to expedite the birth of a breech include evidence of poor fetal condition, for example an abnormal CTG or lack of fetal tone, delay of more than 5 minutes from delivery of the buttocks to the head, or delay of 3 minutes from the umbilicus to the head. What we're wanting to do is prevent birth asphyxia and perinatal morbidity and mortality. So there should be timely intervention if progress is not made once the umbilicus is delivered or if the arms are extended. Again, if you think kind of about it, obviously the umbilical cord is at the umbilicus. So once it's delivered, it's kind of getting squished.
That's a good point. Now, obviously if you haven't seen a breech delivery before, this can sound super scary. Most birth injuries with a breech delivery are from inappropriate handling of the breech baby. This is why it's so important to be taught these manoeuvres by experienced clinicians, not from listening to this podcast alone. Nonetheless, we will post photos of them to our Instagram so you can see what they look like when they're done safely and properly.
Okay, time for another quick recap. Let's get Anne to answer them this time. What are the risks of vaginal breech birth?
Perinatal death of a rate of 2 in 1,000, low APGARs, cord prolapse or compression, head entrapment, emergency caesarean in 40%, soft tissue injury, fractures and C-spine injury.
What are the principles of management for the first stage of labour for a vaginal breech birth?
Await spontaneous onset of labour and avoid induction. Avoid augmentation unless contractions die off after an epidural. Keep the membranes intact. Continuous CTG, FSC is okay. Avoid fetal blood sampling. If slow progress in the first stage, do a caesarean.
And what are the principles of management for the second stage of labour for vaginal breech birth?
Allow up to 2 hours of passive descent in the second stage. If the baby hasn't descended to the perineum, then do a caesarean. Start pushing only once the breech is on the perineum. If the baby isn't out by 60 minutes of active pushing, then consider a caesarean and aim for hands off the breech.
What manoeuvres might be required for an assisted vaginal breech birth?
Let the baby spontaneously deliver to the umbilicus. Use gentle rotation to keep the back up. Use Pinard's manoeuvre to deliver the legs. Let the baby deliver to the scapula. Use Loveset's manoeuvre to deliver the arms. Let the baby deliver to the nape of the neck or the hairline. And use MSV or Piper's forceps to deliver the aftercoming head if it's not delivered spontaneously.
Amazing. Thank you so much, Anne. Okay, so can we please talk about every obstetrician's worst nightmare, the entrapped head?
So, head entrapment is the inability to deliver the aftercoming head and is a serious complication of breech birth. It's an obstetric emergency and urgent intervention is required to reduce the risk of acute asphyxia from cord compression. Head entrapment is more common in preterm breech deliveries. With the term fetus, the diameter of the fetal buttocks is typically similar to the diameter of the fetal head. So generally, if the breech can fit through, then so can the head. With preterm babies, the buttock is typically smaller than the head, which means that the preterm breech head might be caught in a partially dilated cervix. Head entrapment can also occur with larger babies, especially if the mother begins to push before full cervical dilation occurs, or if the head doesn't have enough time to mold when passing through the bony pelvis.
If the head is entrapped, the first thing you want to do is consider uterine relaxation, because this is usually enough to get the baby out. Put the woman in McRoberts and administer a tocolytic. Using IV GTN, the dose is 50 to 200 micrograms. GTN is recommended by Ranskog and up to date, but is based purely on case reports and clinical experience from past decades. There's no clinical trial data because fetal head entrapment is an uncommon emergency situation. And remember that GTN is a potent vasodilator, so there's the potential risk of short-term hypotension with its use. Salbutamol and terbutaline can also be used. Just remember that the onset of action of terbutaline is a bit longer. If that doesn't work, you're in a bit of trouble. There are advanced manoeuvres that can be done, but they all pose significant risk to the fetus and mother. You do not want to be in this situation.
Okay, so the first option is Uterine incisions, and I'm probably saying that wrong. But this basically means cutting the cervix. This is really only helpful for preterm head entrapment where the cervix is incompletely dilated. You basically feel for the cervix and use scissors to make 1 to 3 incisions extending the full length of the cervical lip, typically at 2 o'clock, 10 o'clock, and 6 o'clock. Don't cut at 3 and 9 o'clock because that's where the descending branches of the uterine arteries run and you're just going to cause bleeding. Cutting the cervix basically surgically opens the os to allow the head to deliver. The problem is that the incisions may extend into the lower uterine segment or broad ligament and may injure the uterine vessels, ureter, or bladder. Uterine incisions are commonly mentioned in textbooks, but they are very rarely used. I think I've heard of one case in my last 10 years of practice. Obviously, if the cervix is fully dilated, uterine incisions are useless.
The second option is a Zavanelli manoeuvre. You might recall this from the management of shoulder dystocia. If you've got speedy access to a theatre, you might be able to administer trocholysis and attempt to push the baby back up into the uterus and proceed to caesarean birth. This is a lot harder than it sounds, and outcomes are likely to be poor given the time interval between entrapped head and effecting delivery. The safety of this is unclear because it's so rarely done.
The third option is symphysiotomy, another potential technique that again is very infrequently used. This is where you infiltrate some local anesthetic at the symphysis pubis, put a catheter in the urethra to help push it to the side, and use a scalpel to make a 1 to 3 centimeter incision through the cartilage of the symphysis pubis. This permanently separates the pubic bones, which enlarges the bony outlet to allow delivery of the head. This is obviously an incredibly morbid procedure for the mother. She would typically need to rest in bed for 2 days, then mobilize on crutches until she can weight bear properly. Rarely, she might need an orthopedic repair and have ongoing pain. We really, really want to avoid this option, and again, none of us have ever seen this be done before. This is mostly done in sub-Saharan Africa, where facilities for a caesarean may not be available. There is a simulated symphysiotomy on the WHO Reproductive Health Library if you're interested. Again, it is rarely performed because of a lack of expertise amongst providers and the potential for serious maternal morbidity.
Actually, I have heard of one more technique, and I'm not sure what the name is for it, but I've seen it used successfully for the management of a particularly difficult entrapped head at term by a very experienced breech practitioner. Basically, you push the fetal head back up into the uterus and rotate it into the transverse position. Remember, the transverse diameters of the pelvic outlet is wider than the AP diameter, so this can help to deliver the entrapped head and is significantly less morbid than the other 3 options. If anyone in the audience actually knows what this is called, please enlighten us. You would think forceps would be helpful for an entrapped head, but sometimes the head actually hasn't descended low enough for you to actually be able to apply the forceps safely.
Okay, that's enough. Let's please summarize. Head entrapment is an incredibly rare obstetric emergency, thank goodness. It's more common with prematurity, macrosomia, and pushing too early. We want to avoid it in the first place through patient selection, appropriate labour management, and keeping hands off the breech. And if it does happen, our options are uterine incisions if the cervix is still present, the Zavanelli manoeuvre and a caesarean section, symphysiotomy, or elevating the head and rotating it into the transverse plane.
Okay, that's enough of the scary stuff. Remember, this is a rare obstetric emergency, and these manoeuvres are rarely needed if there is careful planning and patient selection, proper management of labour, and a skilled accoucher. Most vaginal breech births will not have this complication.
Just before we wrap up, we should make a quick comment on preterm delivery. We know that breech presentation is more common in preterm babies, remember up to 25% at 28 weeks. There's also a 9% risk of head entrapment at 24 to 27 weeks gestation. Preterm babies are smaller, fragile, and more prone to injuries with breech manoeuvres. For this reason, preterm babies should not be born by vaginal breech. Elective caesarean section is recommended for a viable fetus when preterm delivery is required beyond 25 weeks of gestation in breech presentation, and this is supported by Ranscog recommendations. For babies under 24 weeks and 6 days, there is no clear neonatal benefit of birth by Caesar for breech presentation. Neonatal outcome at these gestations is likely to be determined by factors other than the mode of birth.
And that's a wrap. Keep an eye out for our summary slides on Instagram. And if you have any comments or feedback, please reach out to us on our website, theuterinesound.com, Facebook or Instagram at theutirinesound, or email us at theutirinesound@gmail.com.